My name is Laura Mannering. I'm a doctor of physical therapy, and I specialize in orthopedics. I also specialize in the Mckenzie Method. I got certified several years ago. Hi, guys. I got certified several years ago, and then I decided to pursue the diploma training, which I completed last year, but the final exam has been postponed due to the pandemic. So as soon as I'm able to sit the final exam and pass it, I will hopefully be a diploma level therapist for the Mckenzie Method soon. I have a practice in Washington, D.C. I had my practice in Fort Lauderdale, Florida for the last couple years, but I moved up here, unfortunately, the first week of the pandemic. I offer office appointments and video appointments. So there's a couple things that I have listed that I want to talk about in terms of what the Mckenzie Method actually is. For those of you who've studied it, this will be something that's a repeat, but sometimes we can hear things again and still learn new things. So obviously the Mckenzie Method is named after Robin Mckenzie. He called it Mechanical Diagnosis and Therapy, which is what he wanted it to be called. He didn't want it to be named after him. However, the name the Mckenzie Method has been kind of taken. People tend to use that instead of the longer version of Mechanical Diagnosis and Therapy, or MDT. So I usually just call it the Mckenzie Method. But Robin Mckenzie did not set out to develop a new paradigm for treating orthopedic or musculoskeletal disorders. It kind of happened accidentally. He was trained as a manipulative therapist in New Zealand. So he was trained as a hands-on therapist. And one day, a gentleman walked into his office with radiating leg pain that accidentally assumed the position of being on his stomach on a bed that was inclined. And Robin Mckenzie was not excited when he saw that that gentleman had gone into the room to be seen and just adopted that position when he was told to wait in the room. But the gentleman, to Robin Mckenzie's surprise, said his leg felt a lot better after that maneuver. Thus, Robin Mckenzie started questioning what he'd already been taught and how different positions can affect not only radiating leg symptoms, but also spine and later down the road, extremity symptoms. So we asked the gentleman to come back and notice that with continued treatment of his back in extension, the gentleman's symptoms resolved. We don't remember, or he doesn't remember that guy's name, so we just call him Mr. Smith. But that example of Mr. Smith is quite profound. Robin Mckenzie therefore started writing down what he saw when he treated patients. He, I believe, amassed notes on 30,000 or 40,000 patients. He was a brilliant practitioner, but he also put in the work and was willing to challenge commonly held beliefs of the public, other clinicians, and himself, because he was not taught to extend the spine of someone who seemingly had a disc problem with pain radiating down his leg. So who can learn the Mckenzie Method? Anyone who treats orthopedic, also known as neuromuscular disorders. So I'm a doctor of physical therapy. I pursued the training in the Mckenzie Method as a specialization after I got my physical therapy degree. Athletic trainers, I believe in most, if not all states, can also pursue training in the Mckenzie Method. Nurses, doctors, physician assistants, chiropractors. So it's not special to a profession. It's special to a way of approaching the body when it comes to orthopedics. When I say it's a way of assessing, that's actually the most important quality of the Mckenzie Method, is that it's a way of assessing. It also is a way of treating, but the foundation is how we assess the body. Now, it might be a fair question, in contrast to what, right? How do other people assess orthopedic injuries? Well, a good number of people assess orthopedic injuries by taking a picture, an X-ray, an MRI, a CT scan. And those are not inconsequential tests, but they're not really, in my opinion, getting to the crux of the matter in the large majority of patients with these complaints. Another way of assessing the body when it comes to orthopedics is by doing clinical special tests. Ones I learned in school, for example, do this test, it'll determine whether or not the ACL is intact. Do this test, it'll determine whether or not the meniscus is at fault, whether or not the elbow tendons are the problem, whether or not there's a nerve root problem. Those tests have their merit as well. I think some of them are quite strong. I believe in the validity and reliability of an ACL test in the clinic, for example. However, I think the majority of those tests are not really telling us what they think they're telling us. They think they're telling us that if you have pain when I do this, you have a tendinopathy. Or if you have pain when you squat and you wiggle your knee, you have a meniscus problem. And I think that those tests were created in an effort to help people. I think they have good intentions. I just don't think that they've withheld the test of time. Ironically, the Mckenzie Method, Robin Mackenzie's work started in the 60s. So it's been around for a while. So we can juxtapose assessing by image with assessing by clinical testing. And then I believe in clinical testing with the Mckenzie Method, which is repeated movements. So in contrast to a test giving you an answer in a minute, we want to do repeated movements. And in the majority of cases, what repeated movements does to the person's symptoms and movement ability over time will help us arrive at a diagnosis. In the Mckenzie Method, we use the word classification. However, I'm comfortable with using the word diagnosis. I feel like diagnosis is just a way of naming a problem. And I feel like in the majority of cases, I can, to a decent degree, tell someone what the problem is. Can I tell them it's specifically one special tendon or one specific part of a joint? No, but I can give a diagnosis that you have a joint issue or you have a tendon issue in the tendon that does this. And that getting that specific doesn't really get us anywhere extra. It's not extra helpful. So the Mckenzie Method assesses the body by using movements repeatedly. That does not mean that every person who has a complaint is getting the same repeated movements. The person's complaints, when we ask them questions about what their problem is, will dictate what movements I ask the patient to do. Common misconceptions about the Mckenzie Method is that it's not an assessment process. It's simply a group of exercises, which it's not. Robin Mackenzie is not unique in that he employs spinal extension with his patients. He and his acolytes are not unique in that we use elbow flexion. They're not rocket science moves. The nuance is in figuring out which movement needs to be performed and how repeatedly, and getting the answer with doing it repeatedly. So the assessment drives which exercise to use. As I've said before, if someone comes in with knee pain and they say, doing a handstand makes my knee pain go away, well, if we prove that to be true, then I want the exercise that you do for your homework to be a handstand. I have nothing against exercises that I haven't been taught. The assessment process is what drives me to figure out how to get to that exercise, whatever exercise it may be. And there are some that don't seem like they would work, and they work. We have patterns, right? We know when people tell us certain things in the history that they're probably going to respond to XYZ exercise, but we allow that not to be true. And we test it before we make that assumption. A second common misconception of the Mckenzie Method is that it's extension only. We use a lot of extension. The primary factor for that is that extension is a position a lot of our joints aren't in a lot. The theory, the hypothesis, is that most joints will resolve their issues if they have a joint issue, if there is a joint issue, by moving in directions they don't go into a lot. So a lot of us do not go into full neck extension or full shoulder extension, etc. So are exercises always going to be extension? No, but extension is used quite a bit. However, there are patients that extension of the joints makes them worse. So it's a constant assessment process. A third misconception is that the Mckenzie method is hands-off and doesn't use manual therapy. That's incorrect. One of the pillars of the Mckenzie method is that we apply force as needed. So we apply the smallest amount of force needed to get to where we need to go. That force is often applied by manual techniques. We use manual techniques as needed. We just aren't often going to go there first. And that creates a safety net for the patient. You don't want to throw, fifth level force at a joint or, strong force at a joint before you know it can handle minor and mild and then moderate force. So the Mckenzie method does use manual therapy. We just believe that safety is important. And secondly, we believe that patient independence is important. We believe that patients can be taught to be self-treaters. And so if we create dependency on us because our hands are magic, then that doesn't encourage the patient to take ownership of the problem. It's not just we want people to be responsible for their pain, but by teaching patients that they can treat themselves, you have someone who, for the rest of their life, hopefully believes that. And when the problem returns, they're much less likely to have to return to the medical system. So it's not, we don't want to touch people because that's just our belief system, but we believe it creates better outcomes down the road. And some of the research, I believe, bears that out. There's not a preponderance of research on the Mckenzie method, but we do know that it's reliable. I'll answer questions after. Thanks for asking a question. Another misconception is that we only treat joints. We don't. We just happen to find that 70 to 80% of people's problems are stemming from joints. Or if they're not stemming from joints, are resolved by moving joints. And that nuance is not an argument I really want to undertake with people, because we want outcomes, and the mechanism of how we got there can be a little bit up for interpretation because the body is so complex. But we don't just treat joint derangements. The assessment process tells us in the macro level, am I thinking that this is a joint-derived problem? Am I thinking this is a tissue-derived problem, either the tissue in the capsule around the joint or the tissue in the contractile tissues of the muscles and tendons? And then the other third big group is called other. But in that other group are things like structural problems, inflammatory problems, non-musculoskeletal problems that create musculoskeletal symptoms. Those are the three main groups of patients. But as I mentioned, 70 to 80% are going to be in that joint group. And the good news about that, and what gives the Mckenzie method a positive spin in a lot of people's minds, is for those 70 to 80% of people with orthopedic complaints who have joint problems, those are the rapid resolvers. So that's how we can get people better faster, is by looking for those, which other clinicians typically are not, because they don't assess the body with that repeated movement assessment that I was mentioning. So those people get better on average 5 to fewer visits. Yes, there is a burden on the patient to perform a home program, but I believe that home programs are a burden that all therapists are giving their patients. We do it differently by typically having people do it frequently throughout the day to ensure success. The fifth common misconception about MDT or the Mckenzie method is that it's only for the spine. It's not, and extremities are really fun to treat with this same methodology. For example, knees have flexion, extension, some rotation, possibly some valgus and varus forces. But for me to deduce what that knee needs, I will look at the knee, repeated movements of the knee, and I'll also look at repeated movements of the spine. The spine is the fuse box, and it sends its output via nerves all over the body. So I strongly believe that if you have an elbow problem, you have to check the neck and the mid-back. If you have an ankle problem, you have to check the spine and the low back. That could be just for a moment. You just quickly look at it and you see there's nothing there and you move on. Or it could take testing over a week or two. The difference there lies in the patient presentation. So the Mckenzie method is not only for assessing and treating spinal conditions, it's also an assessment and treatment protocol or methodology for extremity. So we talked about the classification system, those three major categories, and 70 to 80% are falling in that joint derangement is the word we use, joint derangement category. Smaller percentage in that tissue problem of muscles, tendons, and capsules, and then another percentage is in that larger named group, other, which includes subsets. I'll give you an example. I had my friend call me a couple days ago. Her friend had fallen, was in a lot of pain in her mid-back, and I asked her a few questions, and I said, look, if this could be a couple things, if she's not getting better by tomorrow, go get an x-ray. And she did, and there was a fracture. So obviously this was not an in-depth evaluation of a person in my office, but MDT sometimes I think gets a bad rap for only doing repeated movements, and that's not the case. There's a time and a place to go get an image. There's a time and a place to go get anti-inflammatory treatments. So those patients are in the other. How do we figure out if you're in that other category? Is you don't respond well to repeated movements, right? The assessment will tell me, this is not seeming like a joint problem. This is not seeming like a tissue problem. I really need some more information. Or this is seeming like an inflammatory problem. So we need to get some anti-inflammatory chemical help, either via oral dosage or an injection. So the assessment gets us to what it is. And in contrast to other approaches to orthopedics, we don't make assumptions, right? We can't just say, oh, you hurt yourself yesterday, it's inflammation. Maybe, maybe not. If I move you and you get better, then there may be inflammation, but it's not driving the symptom response. What was driving the symptom response, if I move you repeatedly and it gets better, is that there was a joint problem. Tissue problems will not change in a matter of minutes, but joints, as I mentioned, are the rapid resolvers. They will change, if not in minutes, in days or weeks, we expect. Definitely within a week or two, if we have the right repeated movement, we expect a noticeable change. So when I talk about repeated movements, what does an evaluation look like? Well, I take a verbal history from the patient. I have specific questions that give me specific answers that dictate where I want to go with the physical exam. But each question is purposeful in giving me information about arriving at a diagnosis. Because before I start the physical exam, I want to usually have 2 diagnoses in my mind and confirm or deny them in the physical exam. So the verbal history is not that unique, except for the fact that I am more purposeful with my questions. And knowing how I diagnose, I know I ask different questions than I did, for example, before I started using the Mckenzie method in the earlier part of my physical therapy career. When we get to the physical exam, it's relatively straightforward. I take measurements or baselines of the person, right? So if it's a shoulder problem, we look at shoulder range of motion, we look at shoulder strength, we look at the spine that's related to the shoulder, which would be the neck, sometimes the mid-back. We look at range of motion there, and we look to see if there's any nerve tension. And then outside of those movement or mechanical baselines, we look at function. So if the person says my shoulder kills me every time I do a pull-up or a push-up, that maneuver we want to test in the clinic. We want to know what it feels like so that when we apply an intervention, if it changes, we know we're on the right track if it changes for the positive. So we get those baselines in terms of movement, strength, and your functional ability, sometimes nerve tension. And then, based on everything you've told me, and based on what we see in that scenario of the baselines, for example, if you have not much motion in one direction, but a lot of motion in another direction, that informs what repeated movement I want to try. So it may be extension, it may be flexion, it may be rotation. Knowing that it's true that most people will respond to extension. A lot of us tend to use that first, but it's not, once you get experience with the method, it's not always 100%. But we do use the phrase exhaust the sagittal plane, and the sagittal plane is moving into flexion and extension. Exhaust it first, because even if someone has shoulder pain on one side, moving the neck in the sagittal plane can fix an asymmetrical problem in a large majority of cases. So if we do 10 repetitions of a repeated movement, there's 3 simple responses. Either it has no effect on the person's baseline, it makes them worse, or it makes them better. So if it makes them worse, we don't pursue that repeated motion direction anymore. If it makes them better, we want to do more and see if it holds up. And if it has no effect, then we can we have a few choices there. We can add more repetitions. We can add more force into that direction if we think that the body is ready for more force. Usually it's just more repetitions. On my typical evaluation, I like to do about 30 repetitions to be convinced that we want to continue that movement testing at home. I tell patients that the treatment is in the testing and vice versa, which I think is a very new concept for physical therapy patients. What I think my patients used to expect, or at least I expected as a patient a decade ago, was that on day 1, we knew what was happening. Here's your home program. You need to strengthen this, you need to stretch this, and you need to, minimize this or practice this. And I really think that that's just not the most appropriate thing to do. Clinicians in other fields of medicine use testing all the time. Here, your blood pressure is a problem. Take this medicine for 2 weeks. Come back. Let me know how that went. Stop if anything gets worse. Or a cognitive therapist says, here's a new technique for dealing with your anxiety. Go try this for a month and come back in a month and we'll see how that technique worked for you. Same thing goes for cardiologists. If you're having a heart problem, let's go run a stress test and see how the heart responds. So I think our field in physical therapy was a little bit lost with, we know the diagnosis on day 1, either because an image showed this diagnosis or because our clinical testing on day 1 confirmed this diagnosis. And therefore, with that diagnosis in hand, you just started treatment on day 1. And with what I do now, it's absolutely possible that we start treatment on day 1, but it's not really confirmed that we have the right diagnosis and treatment until the patient comes back. And a lot of my mentors have said the first visit ends when the patient comes back on visit number 2, because if we do 30 shoulder internal rotations in the evaluation and you have a magnificent response, the question then becomes, well, what happens if you do 200 shoulder internal rotations over the next 4 days, right? Or the next 3 days? We need it to hold up. And if it's the right movement and we have the right process, the patient will come back significantly better. And if not, then we have to reassess. This may sound like it's just elongating the process and you're just not even treating until 4 visits in. But that's very wrong. Because the treatment is embedded in the testing and vice versa, I average much fewer visits with patients than I did before I used the Mckenzie method. A lot of that has to do with experience with the method, of course. I've been using it for years and I've sought out a lot of mentorship over the years. And I'm constantly seeking new knowledge, because the more experienced you are with the method, the faster you'll get to that movement that's helpful. Because you'll recognize patterns with thousands and thousands of patients. And so you'll know how to interpret nuanced responses to movement. So it doesn't elongate the process to consider the patient going home with a test, but I think it is a switch for people to actually start thinking like that, because people want answers fast, but people have also been taught that they can get answers fast. They've been taught that you hop in the X-ray or the MRI and boom, that's your diagnosis. And in X-rays, if we're looking for fractures, most of the time that's true. Fractures, however, make up a very small minority of orthopedic problems. But when it comes to MRI, people have been indoctrinated, so to speak, with the expectation that an MRI tells you everything. And for those of you who are listening to me, who are clinicians, you can relate. The evidence is sound that MRIs show abnormalities and problems in people with no symptoms. So to make the jump that an MRI shows that you have a rotator cuff tear, ergo your shoulder pain is coming from that, is a leap. And if you're treating people based on that, you're missing this huge cohort of people, 70 to 80% of people who will get better quickly with repeated movements in the right direction, right? Repeated movements in the wrong direction could make them worse. Repeated movements in a direction that's ineffectual has no effect. But by moving people in the right direction repeatedly, you're going to make a lot of people better fast, despite the fact that we consider it testing over the homework, with the home program. If I send a patient home with shoulder internal rotation repeatedly for 2 days, they come back the same. The next day, I send them home with shoulder extension. They come back the same. The third day, I send them home with shoulder external rotation. They come back significantly better. Well, now we're off to the races. And if we're getting significant change, it's not going to take more than a couple more visits typically to fix that. So but to get to visit 3, we had to go through visits 1 and 2, because I wouldn't have sent patients home with that if I didn't think there was a chance that it was going to be fruitful. There's a minority of times when I send people home with exercises to do repeatedly that I'm on the fence about, but I need to know the answer. I need to know what happens when you sit and flex your lumbar spine 10 times every 2 hours for 3 days, right? Obviously, giving the parameters of stop if anything gets worse, but there's sometimes it's just testing for information versus testing with an expectation. And obviously that expectation, if you're sending someone home with movements with an expectation, the expectation is that it improves them. If you're sending them home just for information, then you're really curious, what is the result going to be? So that's how an evaluation and subsequent follow-ups kind of look within the Mckenzie method. And I will encourage people, if people are watching this live or later on my Facebook page, that the Mackenzie USA or the Mackenzie International website has forms for people to fill out that kind of give a checklist. I think they're called patient briefs. And if you fill it out because of your neck pain, it will give you a good idea if the Mckenzie method would be a useful resource for you for your pain. So I think there's one question. Let's see what it is, if I can figure it out. All right. And John, hi. I don't know if it's pronounced Riyadh, but hi there too. All right. So if the patient has severe sciatica and chronic comorbidities that prevent him from testing and prone lying due to high irritability, irritability, what shall I do? So there's a lot of patients who have chronic comorbidities. Every person is going to be amenable to a certain amount of testing. So if someone is very sensitive to movement, I've sometimes just sent them home with posture correction. If you suspect that an extension force via their verbal history will be fruitful. If you don't, you can still send them home with posture correction and just see the results. The patient, if they can't even move for testing, obviously you have to take it slow, but you start getting some alarm bells, right? But you can start really slowly, just with posture correction, or sometimes slouch overcorrect. If you don't think you can, if you think the person might have a derangement, right? You're looking to see if there's a joint problem you can fix relatively rapidly for this patient population. If you think that, then you want to start to at least get the system moving, right? You can even take it back and say, okay, I just want you to start walking half a mile a day. You know, you can start with just getting the person conditioned to movement so that testing down the road gets you somewhere. But I've definitely had those patients, so I speak from experience. I've definitely sent people home with just posture correction. And, you know, I think a lot of us want to be hands-on with those types of people, but I would caution clinicians that you want to be careful in people that are irritable and present with a lot of other things. And I will say that what I've been learning in the last couple of years is that there are a lot of non-musculoskeletal problems that present with musculoskeletal pain, right? And you mentioned chronic comorbidities. If you Google what creates back pain or what creates joint pain, you'll get a whole slew of things, right? So if you're not getting anywhere with musculoskeletal treatment, don't be afraid to find a doctor in your area who can look at the body holistically and figure out what could be creating those musculoskeletal complaints. Anyone else have any questions? Lynn, I saw your message. I didn't prepare much more. Obviously, I could speak for hours because this is my passion. This is what I do all day long. Well, not these days with the pandemic, but I actually miss speaking in public settings because I feel like it's really helpful to get this education out to the public that if you go through the Mckenzie Method, we want to teach you and empower you to treat yourself during the course of treatment at home and learn the prevention strategies and skills to become someone who can, at a bare minimum, treat their own problem if it returns, but also possibly treat new problems that come up with the basic understanding of how joints work, how tendons work, how muscles work, and how the assessment process can be precise using just movement, and that we don't need imaging in the vast majority of cases. Not just because they don't give us the clinical understanding that movement does to a body, but because we know that imaging shows so many abnormalities in asymptomatic people. All right, so if there's no further questions, obviously I will try to figure out how to post this on my Facebook page if you want to share it with other people. And I can always be reached for simple questions through my social media accounts. So thank you to this enormous crowd for joining me today in my first Facebook Live. And I guess that finishes this for right now. I hope everyone has a good evening.